Ladies and gentlemen, you are welcome to this lecture of tonight, which should be about supraventricular tachycardias. And this medical terminology is applied for any tachycardia that arises from above or at the AV node. It could be sinus tachycardia, it could be physiological, like in pregnancy, exercise, or stresses, different types of stresses. And it could be pathological due to an underlying problem like myocardial infarction, fever, anemia, thyrotoxicosis. And in those cases, you treat the underlying cause. But of course, your main goal is that the tachycardia will not be prolonged because it might end up in cardiomyopathy. In patients with acute myocardial infarction, you don't like them also to go tachycardic, so you give metoprolol. Because in those patients, as we all know, the filling of the coronary arteries occurs during diastole. If there's tachycardia, then this would jeopardize the coronary circulation much more, leading to more infarction. So this classification, I found it quite useful. The supraventricular tachycardias are classified into nodal dependent and nodal independent. The nodal dependent includes the AVNR, that's atrioventricular nodal reentrant tachycardia, and atrioventricular reentrant tachycardia plus the junctional tachycardias. While the nodal independent include the sinus tachycardia, and this is by far the commonest tachycardia you would find and encounter in your medical practice, atrial tachycardias, atrial flutter, and atrial fibrillation. So this is an ECG with neurocomplex tachycardia, and in this patient the rate is like 180. Here it's also like 180. Paroxysmal atrial supraventricular tachycardia are characterized by abrupt onset and then abrupt ending, and as the name implies, that's why it's called paroxysmal. So it comes and goes. And the etiology is either atrioventricular nodal reentrant tachycardia or atrioventricular reentrant tachycardia. Usually occurs in young individuals. Females are much more affected than males. And usually the diagnosis needs Holter monitor or even EPS, that's electrophysiological studies, because it's rarely that you can catch the patient at the time of the arrhythmia. And if you are lucky enough, then the ECG would display the supraventricular tachycardia and you would reach the diagnosis quickly. But some patients come and goes to the emergency room every time complaining of palpitations. By the time they are seen, they are back to their sinus rhythm. So you have to think about that. You have to diagnose it by further doing Holter and even EPS. And this is another complex tachycardia. You might not be able to find the P wave, but the RR intervals are usually regular. And this is a discriminating point between it and the atrial fibrillation, as we are going to have a look at the ECG in the coming slides. This is again supraventricular, narrow complex, regular, but the P wave is not showing up. Sometimes you might find the P wave buried in the ST segment. What's the presentation of such cases? The patients with supraventricular tachycardia usually present with palpitations. And this is most of the cases, maybe more than 95% of the cases. Chest discomfort is very common, panic attacks, shortness of breath, dizzy spells, sometimes even brief loss of consciousness. So how do you treat? You have to advise your patient about avoiding stresses if at all possible to avoid stress, and to avoid also vigorous exercise, caffeine, and you might find lists of things that he has to avoid, but those are the most important ones. In acute attacks, Valsalva maneuver should be done, and it's very important to do it only in the resuscitation room, with everything around you for the resuscitation of the patient in case if something goes wrong, because some patients would have very much sensitive carotids, And what's the treatment of choice? The treatment of choice is adenosine. It's a very effective medication, and it's usually given on a dose of 6 milligrams as a bolus. It should be given rapidly with good flushing, and you raise up the arm so that it would reach the heart very quickly in seconds, and instantaneously you would see the ECG on the monitor changing. So the trace would be changed to sinus rhythm. The curing treatment is electrophysiological ablations, which is now very much available in many centers. And this illustrates atrial flutter with different blocks or variable blocks, 2-to-1, 4-to-1, and 3-to-1. This is atrial fibrillation as evidenced by the absence of the P waves, the unequal RR intervals, very much prominent in the lead below. Sometimes you might find F waves on the isoelectric line as in V1 in this ECG. This is very important to recognize. It's one of the commonest types of arrhythmias, and it's complicated usually by stroke. So those patients need to be diagnosed and treated instantaneously. Most of them would need anticoagulation because it was found to prevent stroke by 67%. We should not miss such an important arrhythmia. This illustration, both atrial fibrillation and atrial flutter are put together so that you can differentiate between the two, and you can recognize both arrhythmias. They are both common, but the most common is the atrial fibrillation. Up next would be low voltage ECG, and thank you.